this package I'm going to give everyone, you guys have, and I will, as I'm moving on, I will be talking about that. So keep that. I will show you guys infection control, and I want you to memorize all these in the first page, what you have. Second page, it tells you how to keep your patient. So start memorizing. What is your contact? What is your droplet? What is your strict? What is your reverse? And make a card of that and start memorizing. Second thing, you guys have position. Remember, I just talked to you about positioning. So make sure you guys know which is your dorsal recumbent, the third one. Dorsal recumbent is the position you can use it for Foley catheter. Are we clear? And also sometime for abdominal assessment. When you're assessing, you can go for dorsal recumbent. Lithotomy one is the next one. Sims is left Sims, prone and lateral when you turn on the stomach, on the side, and knee chest position. So you guys must recognize the positioning. Are we clear? So you guys have here, we already talked about it, and I want you read it and understand. The next page, you guys have hip spica. Are we clear? That is the picture of hip spica. And the next picture you have is with the isolation package. I gave you the isolation package, and you should have in this, is this picture. If not, then you pick up from the back. I have some isolate, go ahead and take that. But you should, maybe turn the pages. Everyone, do you have this picture in your package? And that's a hip spica abdominal binder. Abdominal binder, you're using for what purpose, abdominal binder? For dressing after abdominal surgery, you can use it, but very important, you keep it dry, the skin. Because if you give bath and shower and you put abdominal binder, what will happen to the patient? They can get the skin breakdown. That is why make sure your skin is dry and check if they fit properly. For G2 patients, they pulls out, you can use abdominal binder. This is the one is hip spica, can be on both leg and one leg. Are we clear? That's it. What is in the leg? Third picture. What is in the leg on the third picture? SCD. What is SCD you're using to prevent thrombophlebitis DVT? When patient is laying in a bed and they ask you, what do you use? We call SCD, and also they have used the word intermittent pulsating compressive devices. What are you preventing here? What are you preventing here? DVT. Which patient are you going to use it? Who are laying in a bed. And that's why to prevent. You can go ambulation, you can go stalking, but this is when your patient cannot get up, you can use this. And what does it lead to? What does it lead to DVT? I did yesterday. DVT lead to what? Pulmonary embolism, right down there. What are you preventing here? Pulmonary embolism. Now, next page, you guys have the drainage system. And these are the drain. When we talk, you must know. One is your T-tube, the Penrose drain, the A, and B is your T-tube. And T-tube used for the closed drainage, and T-tube is used for when they remove the gallbladder. Number B on the next page, one of the page you guys have. This picture, you don't have that picture? Look in any other way. I don't know what they do. They can't just put it. You don't have. So this is the drainage. I will see if I have any open package and give you. So everybody has it in your package, and you must know that this is your Penrose drain. There is no bag with the Penrose drain. And what do they do on Penrose drain is it's attached, the skin care is important. Whenever you have a question, Penrose drain, a skin care, because there's no bag. Where do we use the T-tube? You use the T-tube in gallbladder surgery. Then you have this is your, a small one is Hemovac Jackson trap. So these are your drainage you guys have in the pictures. So I gave you these pictures. Then you guys have sizes of insulin and IM injection. You must know the injection. We are going over this package, the one with the isolation. and you have some injection underneath here, insulin, but the intradermal, subcutaneous, you must know. Your package, on the package I left on your desk, so look on there. And then you have these different kinds of tube. I'm going to go over later, but I wanted to show you the positioning. These are Levine tube, NG tube, segment 10, Blackmore catheter. Where do we have done already segment 10. On the second picture, this is your segment 10 tube. Where do we use segment 10 tube? For liver cirrhosis, for stop bleeding. We talked about the 3-bottle drainage. You got to know all these things for your Nclex, however you do it. Then in OB, how to do GTPL, and you have in your is the assessment for GTPL and rules of Nigel's rule for estimating and checking the fundal height. Are we clear? We all should know what is a fundal height. You're going from here to here, you're checking on that. So I'm going to go over, as we are moving on, isolation. Now some of the pages, they have duplicate here. They have 3 pages here. So I will check on that, but I gave you, if anything you're missing, I will open and give you. And so we will check all the things. So for right now, I want you guys to remember we talked about the positioning. You have the pictures of positioning. And infection control, you start memorizing. You got to know. You have to know this page by heart. And you must know who is going in droplet, who is going in contact, and what you're going to use. It tells you in the next page. Now they're going to say if you have a droplet, you must wear mask and gown, and what do you wear, and how far do you keep your patient. So these 2 pages are very important. Are we clear? So I'll leave it for now, and I will check your pages and see everyone we have it. And as I'm moving, I'll review that, and I will review your insulin and the others. But I am going to go back on page number 27. On page number 27, we just finished dysplasia of the hip. I'm going to go on scoliosis. Scoliosis is lateral deviation. Underline the word lateral. And one or more vertebra, and also accompanied by rotary motion of the spine. So they rotate. So very important, lateral curvature. Then underline the word hips are not same. Uneven hip or scapula. Your scapula is higher, hip is different. Are we clear? So uneven your scapula. Scapula is your shoulder and hip. So this is a lateral curvature, and they are hip and scapula is not even. Are we okay? Also, some people have more kyphosis. Kyphosis in the back means like a bending. And bending at the waist, visualize deformity. And flexible deviation corrected by bending or functional or permanent hereditary that can be seen. So scoliosis should be screened in adolescent age. Are we clear? So when do you screen them? Adolescent age. And you tell them, and they are looking, you have to check their hip and the shoulder. Exercise to strengthen abdominal muscle. Surgery can be done, and in surgery, underline spinal fusion. So when they're saying spinal fusion, could be surgery. And Harrington rod, they put the rod and fix the bone. So when they're saying Harrington rod, that goes only in scoliosis. Milwaukee brace, they may use the Milwaukee brace, and only when the curvature is 30 or 40 degree. If the curvature is getting bad, and they're saying increasing more than 40, then what happened? The problem in breathing. Write down on the side. What do you assess if somebody has this problem is the breathing problem? And also wear 4 to 6 years and worn about 23 hours and wear under the undershirt. So they have to wear shirt underneath to prevent skin breakdown, but they got to wear 23 hours. Only you take it off, Milwaukee brace for bath and shower. And also ISOM, if they come back from surgery and they give you Harrington rod, I want you guys to remember is isometric exercise. Then you go on the other side, I want you to add there is after if they did the surgery log rolling, you always go for log rolling and always assess after the surgery also abdominal because they may use the spica, may use the splint. So it can lead to tightness, nausea and vomiting, abdominal distension. Those can be a complication. Isometric exercise means the movement or contraction and relaxation of your large muscle. So scoliosis degree, if it's getting more than 30 to 40 degrees, the problem may be respiratory. They may use the brace or they may do the surgery. Are we clear? And after surgery, always remember log rolling. Those are few questions we should keep it in mind. Cerebral palsy goes in your PEDS question. And is voluntary muscle poorly controlled. The muscle cannot be, cerebral palsy means something wrong with their muscular. And why? Because maybe a brain damage and cerebral palsy. Ambulation, continue ambulation, their muscle weakness, PT and OT exercise, and due to brain damage. There is a brain damage and they have muscle weakness, and underline the word spasticity. The muscles are very rigid. They have ataxia, a repeated involuntary movement and gross motor movement. Wherever you have muscle problem, you have ambulation problem, ADLs problem, continue therapy, and then you go in the next box, muscle relaxant. All whenever you have the word spasticity, when your muscles are getting stiff, give them muscle relaxant. Anticonvulsion, because the brain is involved, anticonvulsion. Feeding problem, and also remember, prevent aspiration. Never tilt backward, but always downward. Whenever you're swallowing, tilt downward. High caloric diet to give them the strength. So cerebral palsy is brain problem, but relating to the muscles. Are we clear? And always think about continue PTOT exercise, continue ambulation, whatever the help the child need. Muscular dystrophy is also atrophy of the voluntary muscle. Same thing, this is also muscle weakness, and because of the muscle weakness, the child falls frequently and they have lordosis, is more in the back, is curve of the back is changing. And they may use brace to help ambulation and continue ADLs, continue activities, and write down the word independent. Even you have muscular dystrophy and cerebral palsy, you want them as much as they can do it. Continue therapy. I want you to add there in muscular dystrophy, they use the Gower sign. What is a Gower sign? They use their hand when they're getting up because they cannot get up themselves. So add their Gower sign, G-O-W-E-R-S, Gower sign. Using hands to get up because they cannot get up. Unable to walk when they go about 9 to 12 years of age. So when they're going 9 to 12 years of age, they may not be able to walk. And it's a muscle dystrophy, and is more common muscular dystrophy in male child. And they also have waddling gait. They cannot walk properly. They use the word waddling gait. And also it's a degenerative disease. So it's more common in men. Gower sign, we must know. What is a Gower sign? Muscle weakness, they cannot get up and they're using their hands to stand up. Are we clear? Continue exercise, continue independent. We have already discussed yesterday Parkinson's disease. It's a repeat, so I will not repeat that, but we all should know Parkinson is important, and you do have the drugs in the corner. Your medications are very, very important. Artane, Cogentin, L-Dopa, Paraldol, Sinemet, and Simitril. Those drugs are all for your Parkinson. And very important to prevent them from fall. Let them do as much as they can do slowly, and aspiration, risk of ADLs. Are we clear? So let them do as much as. Myasthenia gravis, we talked about it yesterday, so I'm not going to repeat it. And what is myasthenia gravis was? Lack of choline. And remember, I told you, where do you look for? On the face. What is the problem on the face? I told you is respiratory problem, swallowing problem, ptosis words. I told you their eyes are closed and they cannot swallow, they cannot talk. What medication do you give them? I wrote it down yesterday. Mastinon, prostagmin, and tantalone. 3 drugs. And mastinon, prostagmin, and mastinon. Those 3 drugs. And what are the other thing I told you? Myasthenia crisis and cholinergic crisis. Cholinergic crisis and myasthenia crisis. Here, they need more medication. Their medications are very low. To increase the dose, here they have too much of medication and you got to stop the medication or give them antidote atropine sulfate. So antidote you can give them here. And we discussed that yesterday. So everyone, Parkinson goes in your neuro chapter, myasthenia gravis, you must know. And now I will go some of the diet question. I gave you the page with the diet. And everyone, remember, you guys have diet. May I borrow your diet one? Your page, just to show them. No, not this. Yeah, and I'll give you back. Now, I have added in the back, 3rd page, if you guys will look, there are some diets. And there are diets, is a clear liquid diet. Are we clear? And in clear liquid diet, now you do have no milk, no juice, no plum. But very important, what does you include in clear liquid diet? Is your bouillon you can give, free broth you can give them, grape, apple juice and cranberry juice you can give them. Fruit drink you can give, popsicle. I want everyone, make sure you look on this page and write it down there because you must know, I gave you these pages. It's you up to how you're going to remember. Now here it only says no milk, no juice with pulp, but you should know what can you give your patient. And what is clear liquid? It's only liquid. It's not a food, it's not electrolyte. So you cannot continue your patient for 1 week and 2 weeks. They will be very much, maybe 2 days, 3 days maximum, but not a whole lot. Clear liquid is a fluid. Are we clear? Now, and then you have full liquid. Full liquid is all clear liquid you can give, cereal you can give, soup you can give, fruits and vegetable, milkshake you can give, ice cream, custard, pudding, full liquid diet. Are we clear? So you must know the diet. And full liquid diet, then you guys have is how do you correct your thirst and vegetarian diet. And in vegetarian, there are a couple of diets. So I'm giving you these. Then you have 1 page in the beginning is types of diet are used in different diseases. Make sure you guys look. And I do talk about some of them. Go over, start memorizing. You are not going to pass the test if you don't know the diet. There are 3 pages of diet. 1, all your diets have this one, summary of diet modification condition. Then you have what are the effect can happen with your with the diet. And 3rd one, you guys have clear liquid diet, full liquid diet. You guys have done. They're not looking whether you remember or not remember. It's going to be in the test. So you have to remember the diet, we are the patient, taking care of the patient. So I will go on this page, but I'm showing you what you guys need to know. Now, I want you to look on page number 28. Is clear liquid diet. You must know what diet goes in clear liquid. Here it says no milk, no juice, and no plums. Full liquid diet means no jam, no fruits, and no nuts. But you got to know what can you give. So that's why I have added there. So make sure you guys know. What is low fat and low cholesterol diet? Who do you cut down low fat diet? For your cardiac patient. If you have a patient with low fat diet, can eat lean meat. Lean meat is good. White meat is good. No avocados. Milk is cholesterol. Bacon, eggs, yolk, and butter. And all that you're looking in the diet. Then you have sodium. No cheese. Cheese is very high in sodium. High roughage diet. That means no white bread without the fiber. Don't give, you can give them high roughage, high fiber. Fiber you include all your grains, all your fruits you can increase, all your vegetable you can increase. Low residual diet, you cut down the fiber. Buttered rice and processed food, no whole wheat and corn and bran. That means no residual, no fiber. Next page, if you move on page number 29, protein diet. Now these are only very limited, but the pages I gave you have all your diet with different diseases. High protein diet. What is good in protein? Egg, beef, meat, and no junk food. We are eating the protein. Look, all your meats are good, and all your beef and roast beef is good. Meat is good in your protein. Renal diet. What do you cut down in renal? Is protein. Low phenylalanine diet. I did in the babies, PKU. And what is PKU? Is phenylketonuria. And you cut down, underline, last line, no meat, eggs, and bread means write down the word no protein. So phenylalanine, you cut down the protein. But the page I gave you has a lot of diet in there, and I have taken out from different books. Are we clear? And you got to start going your diet. You start reading every day and add more knowledge, because your questions are going to be critical thinking. A doctor has ordered clear liquid diet. What food can you give and what do you remove? So make sure you read that clear liquid. Full liquid diet, vegetarian diet, right? And restricted diet, because diet is a composition for your patient treatment. So diet is going to be in the exam. Next page on 29, I'm going to move on glomerulonephritis. Very important in the PEDS question. What is glomerulonephritis? I want you to underline the word in the first box, last line. Occurs 10 days after hemolytic streptococcal throat infection. Any throat infection the child has, child comes in, child diagnosed with glomerulonephritis, but they have a history of streptococcal infection. What do you monitor the child with streptococcal infection? Is number one, they start with fever. Underline the word hematuria. What is hematuria means? The color of the urine that has a blood. And also, before you go on proteinuria, I will add this way when they throw the question. Sometimes you memorize, but you won't understand the question. Early sign of glomerulonephritis is it's affecting the kidney. So write down the word low urine output. So they have early sign, low urine output. And when you have low urine output, the color of the urine is dark color. Maybe tea colored, maybe coffee colored, maybe a brown color. So remember dark color, or maybe they use the word hematuria. That's a very early sign of glomerulonephritis. So what happened? The kidneys are affected and the urine output is getting lesser. Now you start the throat infection, but this throat infection damages what? The kidneys. Are we clear? So your question is, how do you get glomerulonephritis? Coming from sore throat, damaging the kidney, and is affecting glomerulonephritis. The color of the urine would be dark color, and also tea colored, coffee colored, and hematuria. At their low urine output, early sign. Are we clear? And also when your kidneys start getting bad, you remember your BUN and creatinine is going to be high. This is early sign. Late sign means kidneys are bad. Now you write it down where it says proteinuria and edema. Edema can be in early, but now it's getting worse. And hypertension and underlying flank pain. The pain is going to be in the kidney. So where is going to be the pain? The flank area is not going to be right here, but now the kidney. When they say the word UTI, then you have here, when the infection goes to the kidneys, kidneys are retroperitoneal in the back. So your infection travels where? In the back. So patient will have a lot of pain. So remember, late sign would be what? They have flank pain. Very important, your proteinuria. What is proteinuria? Is you are passing the protein. Are we clear? And what does the means are? Your kidneys are damaging. Are we clear? And also your BUN would be high, you're gaining weight would be high, and patient has pain. So what is the meaning is, remember, glomerulonephritis comes from what infection? Streptococcal infection. And where is it damaging? The kidney. Inside the kidney, the infection damages the filtration unit and urine output is getting low, BUN creatinine is getting higher, patients start getting edema, your blood pressure start getting higher, and your kidneys start spilling what? Protein. Wherever you see the protein is coming out from the kidney, your kidneys are bad. Are we clear? And what is the word is called? Nephro. Everyone remember the word nephro. Toxic means your kidneys are bad. Nephrotoxicity, your kidneys are getting better. Nephro means is the word kidney. Glomerulonephritis is kidney. Now, and remember, they have pain. So you can always use for back pain is your pain medication, warm compress, warm bath is always good. And what do you monitor? Now let's go in the treatment, antibiotic. You're going to treat them with antibiotic. It's a bad infection. They may start the steroids, control the blood pressure. Next line, an immunosuppressive agent, they may give them, and restrict sodium and water, bed rest, INO, weight, and calories would be high. But when your kidneys start getting bad, you're going to cut down the protein. Are we clear? So what is important to cut down here? Protein and sodium. Are we okay? And also you check their electrolytes, potassium level. What do you teach child here with glomerulonephritis? I want you to add there the lab. Everyone remember, I repeat, the lab is ESR, erythrocyte segmentation rate, ASO, anti-streptotiter. These are the two tests they will do it. And also teach them to prevent any infection from throat. Are we clear? And why? Your dental care, oral care, and preventing them from getting streptococcal infection. So those are your teaching questions. Glomerulonephritis comes in the kids, and glomerulonephritis means because of your sore throat, the kidneys are bad, and they can go into what? Renal failure, and they're going into what? Proteinuria. So when you are getting protein, that's a proteinuria. So we covered glomerulonephritis. Now when they are saying urinary diversion, the meaning is urinary diversion, you are moving the urine. Where does the urine collect? In the bladder. Are we clear? Now, a lot of time urinary diversion can be when you have a bladder problem and urine need to move from bladder to somewhere else. Are we clear? So that is called urinary diversion. What is one of the reasons for bladder cancer? I want you to write down smoking and chemicals. And smoking is one of the cause also for bladder cancer. I'm telling you, all your cancers are important. And assessment done for bladder tumor, birth defect, neurological problem, and cystitis, and urinary diversion can be done ileal conduit and couch process. And we will talk about that. And what is the meaning is here, the bladder is, they are removing. So what happened, our bladder receives the urine and collects here, and then we pee. But what happened when your urine is not coming here? They have to divert the urine, just like the BM, you do colostomy. For urine, you have some other diversional. Now, so let's go urinary diversional implementation. Nephrostomy word means, underline the word, in incision they give and they put the tube in renal pelvis. Penrose drain after surgery and surgery dressing. So nephrostomy tube means they are putting the tube where? Inside the kidney. Nephrostomy means the kidney. So they are putting the tube in to drain the urine. So they cannot come the urine from bladder. They are draining. Maybe there is a problem in ureter. So some patient, they may drain the urine from where? From the bladder. And what does the patient has? nephrostomy tube. Are we clear? What they have? Nephrostomy. Remember, nephrostomy tube means the urine is coming out. And I want you to write down there, only the tube is changed by the doctor. Prevent them from infection. In your question, what do you do as a nurse? Don't put the urine bag on the stomach. Make sure it's low. Otherwise, what happens? You put the bag here, the urine is going back, and what will lead to? Infection. Very important, your infection is going directly in the kidney. So what do you prevent with nephrostomy tube? Prevent infection. Keep your drainage bag below, do not let it go back. And if there is a problem, the tube is changed only by the physician. No irrigation, no changing of tube by nurses. No RN, not LVN. Ureterosigmoidostomy is ureter, underline the word, detached from the bladder. Detached means they remove the ureter and they anastomose, they are putting together with what? Sigmoid colon. So the urine is going where? It's called ureterosigmoidostomy. Is sigmoid colon. So the urine is coming from where? Sigmoid colon. So they cannot pass the urine through the bladder. Via is a rectum, 2 to 4 hours, no enema, catheteric complication, check electrolyte, infection, urine and stool evacuated towards the anus. Are we clear? So when they are saying sigmoid colon, so it's going in the colon and the urine and stool coming from the rectum. Are we okay? Number 3, cutaneous word. Cutaneous word is a skin. And stoma, ureter, excised from the bladder, and underline the word abdominal wall. Now they have bring the ureter to the abdomen. So as the word goes, when they give you, these are the wording and you are monitoring patient because the urine is not coming and they can pee, but they're coming through different direction. And also from abdominal wall. And stoma on right side below the waist assist with alteration in body image. Whenever you have surgery, body image is there. Ileal conduit. What is ileal conduit? Is portion ureter replanted into terminal ileum and brought to the abdominal wall. Ileal conduit, underline the word, they correct the ureter and attach it with ileum and they bring it to abdominal wall. Check for obstruction. And cock pouch is called also ileal conduit and they can use container. Ureter transplanted into pouch made from ileum with one-way, underline the word way, one-way valve. They only have a valve, and also when they're removing the urine, underline, they use a catheter to empty the urine. Drain the pouch at regular interval by the catheter. So if they ask you what is cock pouch, always remember they have a valve and the patient has to use to empty with the catheter. Are we clear? It doesn't drain. You have to empty with the catheter. So everyone, when they're saying urinary diversion, that means there's something wrong with your patient. What? Either the ureter or the bladder. So they're diverting the urine in different direction. And always when you're losing the urine and the urine is coming out, monitor the skin care is important, prevent them from infection. Now I'm going to move on renal failure. Now we do have patient who goes in acute renal failure, chronic renal failure. Renal failure means your kidneys are bad. When they are saying end stage of renal failure, end stage means you cannot treat them, but they have to go on dialysis, no treatment. End stage, no treatment. Acute renal failure and chronic renal failure. So you have acute. Acute means all of a sudden kidneys are shutting down. Are we clear? Acute means they didn't have diabetes, they didn't have hypertension, but acute, some condition came and your kidneys are getting bad. Acute renal failure is whenever your kidneys are failing and they give you a question, and mostly this goes in acute. And when they're saying oliguria, we all know what happened when your kidney failing, your urine output gets low. Are we clear? So what happened when your acute renal failure? What is the first stage would be oliguria. What is oliguria or anuria? word anuria means none urine output. This one, low urine output. Are we clear? So what is oliguria? Patient pees but is not peeing what they should pee. That means your kidneys are getting bad. And sign of oliguria, 400 cc per day is not enough. That's very less. And what does patient will go? So what happens when your urine output is low, you're retaining fluid. So what will happen to your patient? Hypertension, very important, underline. CHF, underline, they can go in congestive heart failure. And also they can go confusion. What is going to be high? Underline the word BUN and creatinine and sodium and potassium, and monitor their calcium, and underline the word anemia. Whenever your kidneys are affected, patient is going to be anemic. But very important, oliguria means you're retaining fluid. When you retain fluid, you're gaining weight, hypertension, BUN and creatinine is high. You may not be able to breathe because your lungs are getting congested. You may be having what? CHF. Are we clear? So that is always think about, not memorize, but think about. What happens when you don't pee? You start retaining. So what happens when you retain fluid? You have hypervolemia, your blood pressure is automatically high, you're gaining weight, and when you gain fluid here, your lungs start getting congested. Sometimes your question may be, what do you assess in renal failure? May not be weight, and they may be saying, what do you assess? Crackles, because they have a lot of fluid here. So you're assessing the lungs. Now, so what is immediately what happened? Your kidneys start failing, your urine output is low. Everyone is okay? What would be high here? BUN, creatinine, and remember your sodium and potassium because you are retaining. So that goes in oliguric state. Second sign would be, now you start treating, and they start getting better. For burn patients, you think about, they're going in renal failure, cardiac problem. And so what do? Now you start treating them, and now they're going into second stage, which is called diuretic. What is oliguria means? No urine. What is diuretic? Now they start peeing more. So when you start pee, your symptoms are going to be better. And output would be 4 to 5 liter. Now it's getting, and if BUN is increasing, you still have BUN high because of the fluid imbalance, sodium and potassium, and also your increasing mental and physical activity. You're getting more alert. Are we clear? Your everything is going down. Your BUN will go down, your weight you're going to lose, the fluid. What is diuretic? You start peeing more and you're going in diuretic. Now, what is the reason for acute renal failure? Pre-renal reduced blood volume. Anytime you have a cardiac problem, your blood is not getting enough to the kidney. That is why when your cardiac is getting better, how do you know your patient is getting better? Check the urine output. Are we clear? So number one, reduce renal or pre-renal blood volume. Nephrotoxic drug, glomerulonephritis, may be any post-renal obstruction. Like a patient who has a enlarged prostate. What happened in enlarged prostate? They can go in renal failure because they cannot pee, urine start getting collected, they can go in infection and can lead to, again, on renal problem. Now, what do you do? Acute renal failure implementation. What do you do when your kidneys are bad? Always remember, is your potassium level is high, limit fluids. You got to restrict fluid. In which patient you remember restrict fluid? In your CHF patient and renal failure. Why? Because they are retaining fluid. So what do you cut down when your kidneys are bad? You're retaining fluid. You don't give more fluid. Number two is your potassium level is high. Your patient needs right away K-oxalate. Why do you give K-oxalate? To lower the potassium level. Dialysis, maybe you can put them on dialysis. High output stage, fluid as needed. Potassium, when they start peeing more, you always check your potassium level. It can drop. Dialysis time, check the potassium level, iron, weight, electrolyte, bed rest. IV fluids, if they need to get some fluid, they can add fluids. Diet restriction, oliguric stage, limit fluid, TPN maybe after diuretic phase is high protein. After diuretic, what is after diuretic? They're getting better. Now you can increase protein, but remember two things. On your renal failure patient, whether it's acute, chronic, remember your renal failure patient has they are anemic. Are we clear? Why? Because your kidneys have erythropoietin factor that you're building up your iron. So you are anemic. Number two, you remember what is high in renal failure? Your BUN and creatinine. What is high in renal failure? Your potassium, sodium, and phosphate level. So when your phosphate level is high, what is going to be low is your calcium. So the risk for calcium. So what is two things low in your patient who's risk for renal failure or who has a renal failure is calcium, risk for fracture, and anemic. Are we clear? So acute renal, chronic renal failure, I want you guys write down, is kidneys are failing. Chronic means you have a disease which is affecting your kidney. And which are the patients are high risk for chronic renal failure? Number one, your diabetic patient. Diabetic patient. And also, when you have UTI, you keep on getting UTI. You're going to end up in renal failure, chronic renal failure. And also hypertension. Everyone, two things. That's why for diabetic patient, we got to control the sugar to save, and what are you saving here is their heart and the blood pressure. So if your blood pressure runs high, automatically our kidneys are going to be bad, okay? Now, so let's cover that. So everyone knows the word chronic comes because of the diseases. You have hypertension, you have diabetic. Always remember, diabetic patient, the risk for renal failure. They are hypertensive patient, the risk for also renal failure. So there is acute means all of a sudden. They didn't have any disease, but maybe because the heart got problem, maybe they got burned, maybe they got bad infection in the bladder, and it lead to what? Acute renal. But renal failure means is low urine output. When they use the word proteinuria, that means your kidneys are really bad. Are we clear? And what is high here? BUN, creatinine, and your sodium, your potassium, and phosphorus. What is low here is calcium. Okay? So very important that we know renal failure. And what diet do you cut down in renal failure? Protein, sodium, and potassium. Are we clear? And also phosphorus, because you don't want to increase phosphorus because the calcium keep on getting low. So as you move on diseases, you got to see the question with renal. You're going to see the question in cardiac, cancer, and maybe one question, but you got to understand the problem. Now, if your patient has end stage of renal failure, they have to go on dialysis or renal transplant. Are we clear? So if you're going on dialysis, and I said there are two kinds of dialysis. What are the two kinds of dialysis? We said peritoneal dialysis and hemodialysis. So you have hemo and peritoneal. Now, when I'm saying hemodialysis, means your patient is going in dialysis center. Are we clear? 2 to 3 times a week. They are scheduled and they go for dialysis. But what do they have? Remember, they have here they put is for your monitoring is for thrill and also brute. Are we clear? So they put the shunt here, and what do you monitor for shunt? The thrill, that means the circulation is good. And you can feel for them, and thrill and the brute one. And do not use that extremity. Whatever the arm are, don't use the blood pressure, don't take the blood, don't give the IV, do not use that arm because you don't want to cause the blockage. You do not change the dressing, but they go for dialysis, they will check the dressing, but just monitor the arm for circulation. Are we clear? Now, next thing, when they put the new shunt, they give them the squeezing ball for exercise to make sure they're working and they're using their muscle. So they give them a little ball and they can exercise. What do you monitor patient with hemodialysis is do not do the blood work there. Then let's see on the next page if you have anything on the dialysis. No. So let me stick to the page here and I will add few things. Peritoneal dialysis is where? In the peritoneum. Write down the word. Near the umbilicus. Now sometimes they put below, sometimes they can write here. So it's in somewhere in the peritoneum. Are we clear? So where is it, peritoneal dialysis? In peritoneum. So I want you to write down the word. Very important to prevent infection. And complication is called peritonitis. Now, very common complication for hemodialysis patients is air embolism and water intoxication. So everyone remember, we talked about these two words. Air can go in. And what is air embolism lead to? Pulmonary embolism. Water intoxication when they have too much of fluid. And what does you monitor? ICP. Are we clear? Level of consciousness. So what are the two complications of hemodialysis patients are air embolism and water intoxication. Second thing is your patient, these two are very important. Patient goes on dialysis. Before dialysis, I want you to write down in hemodialysis, before dialysis, you must check their weight. Very important. And also, when your patient goes on dialysis, give report to the dialysis center. When your patient, and no medication, write down here, no medication for blood pressure, antibiotic, and digoxin, or write down the word is water-soluble drugs. Water-soluble drugs, you do not give them. When do you give the medication? When they come back after dialysis. Are we clear? So when do you give the drugs for them? After hemodialysis. But when they're going, because what happened, they're washing out the drugs from their body. Are we clear? So they will be very dizzy and the drugs are not working. So a doctor don't tell you, but as a nurse, we got to know that your patient goes on dialysis, add on the med book. I'll tell you, nurses don't pay attention. They keep on giving medication. You have no clue what they're doing. So a lot of people, we don't even know. Doctors don't write everything. We have to be sure that we are holding the drugs and add on your med book with the doctor order. So remember, give the report. Now when your patient come back, very important, check their vital sign, blood pressure, because the risk is fall because of hypotension. So you got to give your report. What drug are you giving to your patient? And when your patient come back after dialysis, you monitor for diet orders because there's a lot of diet change. And your dietitian should monitor the diet, and we need to because they're restricting the phosphorus, potassium, a lot of diet. So they have to be on a special diet. And remember, restrict fluid. All your patient is in dialysis, restricted fluid, very important, your answer. Follow the diet order. What diet are you going to give? So check what dialysis is telling us. And so everyone is okay? Hemodialysis, air embolism. I said water intoxication. What do you do for air embolism? Lower the head of the bed. Remember, turn the patient on the left side. What is you do after your patient come back? Follow up that dialysis order. Are we clear? What do you monitor your patient? Weight before and after, both is very important, but very important for safety when your patient is going, you do not give medication, but check their vital sign, the weight and medication, give report to your dialysis. But when they come back, is make sure you tell your nurses to put your patient back. They're very tired, 4 or 5 hours. They've been on dialysis, they've drained out the fluid, and they feel dizzy, they feel nausea and vomiting, but we don't realize. But your patient is going through, so we got to make sure they put them in bed. What happened, they can fall, they feel very dizzy, hypotension. Hemodialysis complication is peritonitis. What is sign of peritonitis? Cloudy fluid. When your color of the fluid is become very cloudy, and it can lead to peritonitis. Sterile technique is important to maintain with peritoneal dialysis. I want you to remember one thing for peritoneal dialysis patient. There are fill process when the patient does, and they fill, and then they dwell. I want you to write down these words, and drain. Everyone should know this is important, dwell. What is dwell means how long the fluid is going to stay in the peritoneum. How long are you going to leave is ordered by the doctor. So what doctor ordered? The dwell time. Are we clear? So what is the doctor is ordering? Dwell time. If doctor said you have to hold the fluid 4 hours and you did not drain it and you hold it for 6 hours, your patient is going into hyperglycemia. Are we clear? So don't leave it too long. So what is important? You filling the fluid. Patient does, they hang their fluid and they sit down and they let the patient, the fluid go in. How do you let the fluid go in? By gravity. How do you let the fluid drain? By gravity, from higher level to lower level. And once the fluid is in, we call the dwell stage. And what is a dwell stage? You leave that fluid for longer time. Are we clear? So everyone, now everything is not there. Same thing I did in a Spider-Man. I talk more to give you more knowledge because questions are only your patient-based question. Patient says, I did not follow dwell time. What are you going to monitor? Hyperglycemia. What do you monitor when your patient says the cloudy fluid is coming out? Sign of peritonitis. Very important, a sterile technique. They should be very careful is when they're giving this. For hemodialysis, it's not very important that sterile technique, but what is important, the water, what they're using, water safety measures in the hemodialysis. Are we clear? Now, I want you guys to write down 2 more things because these are in a Spider-Man package and they have asked in the exam. In peritoneal dialysis patient, when patient is calling you from home and they're saying the fluid is not draining. So I'm talking about peritoneal dialysis, return fluid. Fluid is not returning enough. Or when I'm doing my dialysis, the fluid is not coming up. What do you tell your patient? Is turn from side to side. Maybe helping ambulation, positioning, because what happened, the drainage sometimes helps them when you turn the position. Number 2 is constipation. Make sure your patient is not constipated. In your answer, increase fiber, but don't increase water because they are dialysis patients. Are we clear? They cannot drink a lot of water, but yes, prevent from what? Constipation. Maybe give fiber and drink water, but don't say increase a lot of water because you don't want to overflow it. So one question, fluid is not returning back. Second problem, patient says, I'm having abdominal cramping. So what happened, abdominal cramping? It's common. So your answer would be, every patient would feel cramping in the beginning because you are not used to. But what can you help to prevent cramping? Warm the solution. So they don't advise them to take out the fluid and insert. They have a heating pad. You put your fluid, or they use any warming pad, even heating pad. They can wrap them around, they warm them, and then once the fluid is warm, that helps them to prevent what is pain. So what do you teach your patient? So these questions do come in the test. What do you tell the patient? What do you tell patient if they're holding dwell time is more than hyperglycemia? Now, patients who are in dialysis, you must monitor. How do you know your dialysis is working? So your answer would be, how do you know your dialysis is effective? Effective means it's okay and it's working. So what will happen? You are removing the excessive fluid. The purpose is you're removing fluid So patient is not gaining weight, but they're losing weight. Are we clear? They're maintaining. They're not gaining. What does gaining mean? They're retaining fluid, number one. And effective dialysis, your potassium level is low. Are we clear? Electrolytes. What is electrolytes is important. Your sodium, potassium, phosphorus, and calcium. So your answer would be your electrolytes are returning to the normal level. Are we clear? That is the purpose of dialysis. Your BUN and your creatinine level is going down. If you're retaining fluid, you are more higher your BUN and creatinine. When you remove those fluids, your BUN, creatinine, sodium, potassium, calcium, phosphorus, all that level is going to be in normal. So we finished that. We finished glomerulonephritis, hemodialysis. Everything what you should know, I have already said. Are we clear? So those are your questions. You can get that. And I will do one thing, and then I think we should take a break before I start the next page, okay? So